Okay, picture this. An infection that moves so fast, it can take a perfectly healthy person and put them in critical condition in less than a day. That right there is the terrifying reality of meningococcal disease. It's a true medical emergency, a frantic race against the clock for doctors, and you can imagine just a devastating blow for patients and their families. So in this explainer, we're going to break down this incredibly dangerous disease and figure out exactly how we can fight back.
All right, so here's our game plan. We're going to tackle this in 4 parts. First up, we'll get to know the threat itself. Then, we'll dive into how it attacks the body and what that looks like. After that, we'll cover diagnosis and treatment, our defense. And we'll wrap up by looking at prevention and what happens to those who survive. So let's jump right into section 1. We're going to start with the basics. What exactly is this disease and who does it tend to hit the hardest? So at its core, meningococcal disease is caused by a bug called Neisseria meningitidis. Now, when this bacteria decides to go on the attack, when it becomes invasive, it causes absolute chaos. It usually shows up in one of 2 ways. First, there's meningitis, which is a super dangerous swelling of the membranes covering your brain and spinal cord. And then there's septicemia, which is basically a life-threatening infection of the bloodstream that leads to shock and organ failure. And here's the really scary part. These aren't mutually exclusive. A patient can have just one, or terrifyingly, they can have both at the same time.
You know, this disease isn't just random. It has preferred targets. We see what's called a bimodal age peak, which is just a fancy way of saying there are 2 main groups that get hit hardest. The first group is infants under a year old, right around the time the immunity they got from their moms starts to wear off. The second peak? That's adolescents and young adults, from about 16 to 23. This is because they're the most likely to be carrying the bacteria in their nose and throat, even if it's not making them sick. And as you might guess, situations with a lot of people in close quarters, think college dorms, military barracks, that's a perfect storm for transmission. On top of that, some people are just more vulnerable because of their biology. Things like not having a spleen or having a very specific type of immune deficiency can make someone literally thousands of times more likely to get sick.
All right, so that brings us to a huge question. How does a bacteria that's just hanging out in the back of someone's throat suddenly turn into a full-blown body-wide crisis? Let's get into the nitty-gritty of its attack plan and the signs you need to watch out for. Okay, let's meet the villain of our story, Neisseria meningitidis. Under a microscope, these guys look like little pairs of spheres, which is why we call them a gram-negative diplococcus. Now, that gram-negative part is super important because it means its outer shell is loaded with the toxin we're about to talk about. But its real superpower? It's this slimy sugar-based capsule on the outside. Seriously, think of it like an invisibility cloak. It lets the bacteria sneak right past your immune system's security guards. And this cloak comes in a few different flavors, which we call serogroups. The ones you hear about most, A, B, C, W, X, and Y, are responsible for almost all of the disease we see in humans.
So how does the invasion actually happen? Well, it all starts when the bacteria sets up camp in the nasopharynx. That's the space way back behind your nose. And for a lot of people, that's it. It just lives there, totally harmless. But in someone who's vulnerable, it makes a move. It punches through the lining and gets into the bloodstream. And once it's in the blood, that invisibility cloak we talked about protects it, letting it multiply like crazy. And this is where things go from bad to catastrophic. The bacteria starts shedding little pieces of its toxic outer wall, a substance called lipopolysaccharide, or LPS. This LPS acts like a massive panic alarm for your entire immune system. It triggers what's known as a cytokine storm, a huge, out-of-control inflammatory reaction. And it's this storm, not the bacteria itself, that causes all the damage: leaky blood vessels, blood pressure crashing, organ failure. It's absolute systemic chaos.
Now, spotting this disease can be really, really tough because it looks completely different depending on how old the patient is. In a tiny baby, it might just look like a fever, crankiness, or not wanting to eat. I mean, that could be anything, right? A huge clue in infants, though, is a bulging fontanelle, that soft spot on their head. But in older kids and adults, you get the more classic signs we associate with meningitis: a killer headache, a really stiff neck, and finding bright lights unbearable. But I want you to pay close attention to those sepsis red flags for kids, things like leg pain, ice-cold hands and feet, or just weird-looking skin color. These are such critical clues, but they're so easy to miss in the beginning. And this is the sign that every doctor dreads seeing. This is not just any rash. This is what we call a purpuric or petechial rash. What you're actually seeing is bleeding under the skin, and it's a direct result of all that blood vessel damage from the cytokine storm. There's a simple test you can do called the glass test. If you press a clear drinking glass firmly against these spots, they don't disappear. A normal rash will blanch or turn white. This doesn't. And a non-blanching rash like this, it's a 5-alarm fire, a true medical emergency. All right, quick review of what we just covered. The bad guy is N. meningitis. It uses its capsule to get in and then releases a toxin, LPS, that unleashes chaos. Remember, the symptoms change with age, and that non-blanching rash is a sign you absolutely cannot ignore. And the big takeaway here? The real killer isn't the bacteria itself. It's the body's massive, over-the-top reaction to that toxin. Okay, so we know the enemy and we know its battle plan. Now let's switch gears and talk about our defense. How do we actually diagnose this and fight back when the clock is ticking so fast? With this disease, the whole process kicks off with just a strong clinical suspicion. You have to think of it to find it, and you can't afford to wait and see. The immediate steps are to get blood cultures. You're trying to grow the bacteria in a lab. If you're worried about meningitis, a lumbar puncture or spinal tap is essential to get a sample of the cerebrospinal fluid. But here's the absolute #1 rule. You never delay treatment to wait for these tests. Ever. Getting the bacteria to grow from blood or spinal fluid is the gold standard for proof, but there are also faster PCR tests that look for the bug's DNA and can give you an answer much sooner. And when you get that spinal fluid sample back from the lab, it tells a very dramatic story. See, normal spinal fluid is crystal clear, just like water. But in meningococcal meningitis, it's cloudy. Sometimes it even looks like pus. The pressure is sky high. It's swarming with white blood cells called neutrophils, and the protein is way up. And check out the glucose. It's low. Why? It's simple. The bacteria are in there having a feast, literally eating up all the sugar to fuel their invasion. If there is one single rule you take away from this entire explainer, let it be this. You do not delay antibiotics. Not for anything. If you even suspect meningococcal disease, treatment has to start right away. We're talking sometimes even before the patient gets to the hospital. Paramedics can give the first dose in the ambulance. Once they hit the ER, the sequence is get blood cultures and then immediately, we're talking minutes, start a powerful IV antibiotic like ceftriaxone. At the same time, you're throwing everything you have at them for supportive care, like IV fluids and oxygen, to fight the shock. Now, once the lab results start coming back, you can get a little more strategic. They'll tell you exactly what strain you're dealing with and which antibiotics work best against it. We call these susceptibilities. If it turns out the bug is sensitive to good old penicillin, fantastic, we can switch to that. If it's a bit resistant, we stick with the heavy hitters, like ceftriaxone. The whole course usually lasts about 5 to 7 days, all through an IV. And here's a really important clinical pearl. For some other types of bacterial meningitis, we use steroids to reduce inflammation. But for confirmed meningococcal meningitis, nope, steroids are actually not recommended. Okay, this is a really interesting final piece of the puzzle. The patient has survived the life-threatening infection. They're getting better. You'd think that's the end of it, right? Well, not quite. We still have to deal with the fact that the bacteria might be silently hiding out in the back of their nose and throat. The IV antibiotics that save their life, like penicillin, might not be great at getting rid of it there. So, to make sure they don't become a carrier and spread it to someone else, we give them a short course of a different antibiotic right at the end of their treatment, just to wipe out any squatters. So let's wrap up our defense playbook. First, you have to suspect it. Then you confirm it with lab work. Treatment, antibiotics. Right away. No excuses. Then you clean up any lingering bacteria in the nose to protect everyone else. But the key point, the life-saving point, is speed. Getting that first dose of antibiotics on board as fast as humanly possible is what makes all the difference. And that brings us to our final section, which is all about the best possible strategy, stopping this disease before it even starts. We're going to talk about our shields, the vaccines, and we're also going to face the tough reality of what life looks like for the people who manage to survive this. When it comes to prevention, let's be clear, vaccination is our single most powerful weapon. We've got a couple of main types. There's the MenA-ACWY vaccine, which covers 4 of the big serogroups, A, C, W, and Y. This one is recommended for pretty much all adolescents. Then you have the MenB vaccine. This one is crucial because serogroup B is a really common culprit, especially in that adolescent and young adult age group. While it's a must for high-risk folks, it's really something every family should talk to their doctor about for their teens. And the good news is, we now have awesome new vaccines that combine all 5 of these into a single shot, which just makes everything easier. But what happens if you've already been exposed to someone who's sick? That's where something called chemoprophylaxis comes into play. It's a big word for a simple idea. We give a quick course of antibiotics to people who are in close contact with the patient to stop them from getting sick too. We're talking about household members, maybe kids at the same daycare, or anyone who is directly exposed to their respiratory secretions. And this is so important that we recommend it for all close contacts, even if they're fully vaccinated. It's an extra layer of protection you just don't want to skip. Now, this is the part that's a really tough pill to swallow. Even with all our medical advances, the prognosis can be grim. We're still looking at a mortality rate somewhere between 5 and 18%. Think about that. Up to almost 1 in 5 people who get this disease don't survive. And for those who do pull through, as many as 20% of them are left with major life-altering complications. This disease leaves scars, both visible and invisible. So what are we talking about when we say complications? Honestly, the list is heartbreaking. The most common one is permanent deafness. But beyond that, survivors can be left with learning disabilities, seizure disorders. You can have severe skin scarring from where that rash was. And in the most severe cases of septic shock, amputations, losing fingers, toes, sometimes even arms or legs. And we can't forget the psychological trauma. The rates of PTSD, depression, and anxiety among survivors are incredibly high. It's a battle that continues long after the infection is gone. Okay, so if you remember only 4 things from our entire discussion today, make it these. Number 1, this disease is fast, it's deadly, and it loves to target infants and teens. Number 2, that non-blanching rash, the one that doesn't fade under a glass, is a code red emergency. Number 3, when in doubt, treat. You start antibiotics first, period. You can figure out the details later. And finally, number 4, prevention is everything, and our best form of prevention by far is vaccination. So I want to leave you with this final thought. We have the tools, right? We have highly effective vaccines. We have antibiotics that work. So why is this still happening? Why does this disease continue to steal lives all over the world? What are the biggest hurdles we face? Is it awareness? Is it cost? Is it getting vaccines to the people who need them most? That's one of the biggest questions we have to answer in global public health.